All right, sir. Can we start now?
Yeah.
All right. So I request the attention of the faculties and the delegates. I will take a few minutes of yours and let me introduce me and the faculty members of the session. Good evening and welcome to one and all. I'm Ankita from Planet, the designated station assistant for a seamless experience. And Planet is India's most trusted and widely used tech platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Indian Society of Pediatric Neurosurgery. And topic of today's session is decision making in hydrocephalus. So without any further delay, I would like to hand over the session to Dr. Suhas, sir. So over to you, sir. Kindly proceed.
Thank you, Ms. Ankita. So good evening, everybody. Good evening to all of you who have joined us. So we have the Indian this is a session conducted by the Indian Society for Pediatric Neurosurgery, and these are part of the virtual classrooms planned to be run over 24 to 30 months, and we plan to cover most of the topics of pediatric neurosurgery through faculties and faculty of Indian Society of Pediatric Neurosurgery. So today's topic is decision making in hydrocephalus, weighing between options. Anybody who has practiced or seen hydrocephalus knows that how tough this topic is, and how tough decision making is, and how crucial it becomes for any child or anybody who has hydrocephalus. We realize that any mistakes done during the decision making stage can become a very crucial one for the future of the child, and especially when it happens during the precious years of brain development. So the teacher for this session is Dr. Kaushik, who is a consultant at Park Clinic at Kolkata and a professor at the medical college there. We have started a new initiative of having a guest department. So this time the guest department is Government Medical College of Trivandrum, and the professor joining us from Trivandrum Medical College would be Dr. Biju Bhadran, and there would be his residents who would be presenting his case. This is the new initiative for as a part of a personal rapport between the Indian Society of Pediatric Neurosurgery towards specific departments and creating awareness of topics of high impetus of pediatric neurosurgery for these residents. So Kaushik will talk on decision making, and then from there we'll go on some case presentations, and then we'll have open questions for discussion. Thank you. Kaushik, you can start off.
Thank you, Shivas, and good evening to everybody. And let me start directly with the topic, and then we can go to the case discussions. Just give me a minute.
Thank you, Dr. Biju. Dr. Biju has just joined. Kaushik, Biju is our guest teacher.
Hi, Dr. Biju. So can you see my screen and hear
Yes,
mine?
yes. Yes, go ahead.
So good evening. The topic for today is decision making in pediatric hydrocephalus. As Dr. Shivas has told, that this is a very important topic that we all face in our day-to-day life. You know that the hydrocephalus is an old disease. References of hydrocephalus is found in Egyptian literatures, and Hippocrates described hydrocephalus in details. The Greek used to treat hydrocephalus like subdural, thereby trephination, and putting in bands of twisted basswood bark inserted through refined holes in the skull. And the first clinical description and operative procedure was done by the Arabic physician Abu al-Qasim al-Jawhari. And then after the Renaissance, there was development of understanding of the CSF for circulation. And then in the modern era, around the 1950s, we have the development of shunt tubes. And there's from then on, there's a progressive development of various types of shunt valves, and which has complicated the scenario for a young resident who has just passed. What shunt to choose, what valve to choose? This is a very difficult question. PP shunt has transformed the life of children. They have minimized the death rates from 54% during the 1950s to less than 2% now. There's a significant improvement of intellectual dysfunction that used to be occurring in some years ago, some decades ago. But the shunts have, because shunt is a nightmare for the pediatric neurosurgeons and the parents, because overall shunt failure rate is 40% in first year, 50% by the second year, and 70% of the shunts fail by the 5th year. So the first decision, whether to shunt or not, and if yes, then what shunt to choose is a crucial one. That's why the Indian Society for Pediatric Neurosurgery have started to delve with this topic today. Humans have almost reached the stars, but we are yet to find a suitable shunt. If anybody interested, you can go to this beautiful review paper published in Child's Nervous System in 2015, whether there's an ideal shunt or not. And I give you the answer, even 7 years from this paper, there's nothing called an ideal shunt. You have to make best use of whatever you have. So why is the treatment of hydrocephalus with shunt so elusive? This is elusive because there are various types of hydrocephalus. It may be classified on the types of onset of hydrocephalus, whether it is congenital acquired, whether the causes of hydrocephalus like primary, secondary, idiopathic, based on underlying lesions, whether it's a tumor or post-hemorrhagic or post-infective, or depending on the pathophysiology, where there is a CSF overproduction, CSF reabsorption defect, and so on. So there are 180 different causes of hydrocephalus described in modern literature with 54 subtypes, 10 categories. So one single treatment of a shunt cannot address all of these types of hydrocephalus. So hydrocephalus treatment with shunt is very individualistic. You have to look to the patient, look at his or her scan, look at the possibilities, and then decide on your own what type of shunt should be the best for him or her. You may be wrong. Then in the first failure, you have to correct yourself and then again re-venture to put in a shunt that can work best for that child. The CSF quality varies widely. There may be CSF with high protein, CSF with high cells, CSF with low sugar, and normal with CSF. Every type of CSF will not flow equally to a standard type of shunt. We do not have shunts for every, because the rheological property of CSF will vary inside the same shunt. There are different patient demographies. A neonate is recumbent, an older child is sitting or standing. The child may be in warm climates like in Africa or in India, or they may be in cold climates like in Britain. Everything will affect the CSF flow to the shunt. The child may have an open fontanelle, the child may have a closed fontanelle. The intra-abdominal pressure is different depending on abdominal shapes, abdominal pathology. So again, you have to choose the shunt looking at all these parameters. Don't just jump in, medium pressure, low pressure, let's go and do the shunt. You have to see the shunt receptacle is abdomen. So you have to study the abdomen also before putting in a shunt. You have to study the valve depending on the climate also. We'll come to that. Then there are various multiple shunt components. Ventricular catheters comes in every shape and sizes. And so as the introductor, the connectors, whether to use a connector or not. And as you all know, there are myriads of shunt valves allowing different flow of the shunts. So before we go on to this choosing a shunt, we must remember what are the perils of shunt. A shunt may cause an overdrainage. A shunt may cause a blockage. The shunt block may be in the proximal end if the tip is touching the ventricular wall or the choroid plexus or obliterating the hole, or in the distal end if the omentum blocking the hole, or there is the formation of abdominal cirrhosis in a neonate. The shunt infection is a very common risk, which is described around even in the best centers, the risk will be somewhere around 5 to 10%. In a neonate especially, there is a risk of shunt extrusion, both the proximal end and even the distal end. Distal end means the part across the valve may be eroded away because of the pressure on the normal chavra shunt that we use. And the shunt may migrate out, and the papers have been in the literature describing shunt migration from every possible orifices. And it may be occur both in the proximal end and in the distal end. Shunt may break. Usually, if we use multiple connectors, the shunt may break from the connectors. And multiple shunts may affect the CSF flow. If you put in a third shunt, already two shunts in place, which are partially blocked, then the CSF dynamics is different from a virgin shunt. So all this consideration has to be taken by one single person, that is the surgeon, and the child and his or her parents look up to the surgeon to choose the right type of shunt. It is a very, very difficult. But it's not an appendix surgery. It's not a gallbladder surgery. It's very, very difficult for to learn how to choose a shunt. Shunt surgery success is 50% surgeon dependent, 30% is physiology dependent, 20% material dependent, and you are expected to consider all these three before choosing the shunt. So, can shunt be how to plan a shunt insertion? The planning of shunt must encompass, number one is choosing the right valve as per the age to prevent one issue, that is over drainage or under drainage. So in neonates, since the abdominal dynamics is different, since the neonates is in recumbent position, since the fontanelle is open, it is better to put in a temporary shunt like a ventricular subclavian shunt. In infants, if you are that is across the age of 1 month, preferably when the child is more than 3 kgs or 3 months old, to put in a VP shunt with a low pressure valve. Then in the older children who is learning to sit or learning to stand, it is preferable, theoretically preferable, to put in a shunt with a programmable valve so as to avoid over drainage and under drainage. I am negating all the other issues like the availability issues, like the cost issues, but ideally as doctors, as a medicine specialist or surgical specialist, we should choose a programmable valve with a over drainage control device is probably the best option. Then you have to choose a shunt. Think about the receptacle where the shunt is going. If the abdomen is normal, especially in the neonates, it is okay to do a VP shunt. If it is a premature infant, it is always better to do a temporary VSD shunt, as the abdomen may not be ready to receive the CSF bulk flow. There may be risk of necrotizing enterocolitis and other even paralytic ileus, reflex paralytic ileus once a bulk of CSF comes there. If the abdomen is scarred because of the previous shunt, is scarred in multiple places, it is better to put in the shunts in the pleura. If the pleural space is inadequate, in very rare cases, you can put in other receptacles like the ventricular atrial shunts, or even some rare spaces like ventriculocholecystal, or even in the ventricular vesicle shunt, that is in the urinary bladder. Next, you have to choose a right shunt as per the CSF quality. If the CSF is clear and sterile, the shunt we can put in easily a VP shunt. In an infected CSF, it is always advisable never to put in a VP shunt and put a temporary VSD shunt. Many times, as you see in our laboratory reports, that the reports are equivocal. Some sugar is, say, borderline low, 28 or 30 like this. Protein are borderline high, not very high. You are tempted to do a VP shunt. But in a small child, it is always better to have a, whenever there is a doubt, put in a temporary shunt rather than going for a permanent shunt. If the CSF has a markedly high protein, as in post-tubercular meningitis, then it is recommended to do an external ventricular drainage. Pass the hot phase, that is in say around 2 to 3 weeks. Once the grade of the patient improves, the neurological grade improves, the CSF becomes better to put in a VP shunt. If there is a hemorrhagic CSF, as in post-germinal matrix hemorrhage, then it is better to have a VSD shunt or a ventricular access device, that is a temporary shunt. Next, what are the things that you should think of before to prevent shunt breakage, erosion, and migraine? One thing is to minimize connectors wherever possible. What type of shunt you choose? Choose a shunt which has minimal connectors. If you are using connectors, you must ensure that the connectors are fixed with a non-absorbable sutures like silk and proline and not Vicryl. We have to take care that the patient is not overtly constipated in the post-operative period. Remember, many a child, we used a neurosurgeons tend to overlook it. Better talk with a pediatrician will reveal many a children, small children are constipated. So this kind of constipation or can then if it is if the and you can have some novel techniques like this subpericranial shunt valve placements, which is a technique in patients with triable skin, so that that shunt exclusion, what I showed in the picture, can be avoided. You are advised to read this paper, which is published in Child's Nervous System in 2014, a very good technique where you can avoid overlying skin necrosis in a neonate with a very thin skin. Next, about how to choose a right shunt to minimize infection. Obviously, you all know about this antibiotic coated shunt, where the shunts are covered with clindamycin and rifampicin. And it is, as you all know, it decreases infection rate significantly from 16% to 6%. But you remember that the shunt valve is not coated, so it is unprotected. So you have to take the same care of the shunt valve as you would do if you are using a non-antibiotic coated shunt. And the most important thing to understand for the residents is that this protection from infection is mainly for the first 1 to 2 months, or at least 6 months. Afterwards, the chance of infection of an antibiotic coated shunt and a normal shunt are almost the same. And in our country especially, the local flora which are happening in the shunt infection cases are mainly gram-negative. So rifampicin may not work in patients in our settings. Lastly, as a surgeon, it is your duty to choose the right environment to minimize shunt infections. You have to have a strict adherence of the OT to asepsis, antisepsis, use antimicrobials, and prevent hematomas. Please again refer to this paper by Choksi and Malik, where with zero tolerance to shunt infections, can it be achieved? It can be achieved. At least nearly it can be achieved if you follow a strict institutional protocol. I would request all residents here to develop a protocol according to your own institution and follow it strictly. Train your staff, train your OT boys, and then follow it strictly. So this institution-specific protocol for a shunt is always work. Every institution, you can see the outcome in literature. These are prospective cohorts, and you can see on the extreme right side of the screen where the arrow is given, how the outcome for shunt infection has reduced from in the first case, see from 13.2% to 3.5%. In every case, it is reduced. So choosing institution-specific protocol, making a protocol, training your staff, training your OR staff, training your sisters, training your co-PGTs, training your other people who can be in the theaters, like the anesthesiologists, is a must. And we can give, and there's a guideline which I'll show in the later. Now coming to the decision making of a VP shunt. So this is very, very important. And I'll illustrate with some cases. Say this is a case one. This is a case where you can see that a neonate, and this neonate has a triventricular hydrocephalus, though the fourth ventricular looks big. Now this is a congenital hydrocephalus. There's no history of fever. There's no history of maternal infection. And you know, in infants, in neonates, especially in premature neonates, the ventricular absorption is not also proper. So even the fourth ventricle may be dilated, even if it is a classic case of an aqueductal obstruction. But the fourth ventricle may also seem big, as a CSF reabsorption is not proper. And this is, as you know, for this case, we have to do a CSF analysis. Now, this CSF analysis is a must for all types of hydrocephalus. When a patient comes to a OPD or is admitted through year, and especially in a small child like neonates or aged 1 to 3 months, they are prone to infections. You never know from where they are coming, whether they already have a shunt infected or not. So never put in a shunt without doing a CSF analysis. Do a ventricular tap, do a diagnostic ventricular tap, and assess the CSF before deciding on the shunt. This is a mandatory step in all types, even if it looks like a plain and simple aqueductal stenosis. Please do a CSF analysis always before putting in a shunt. Now, with an older child with a closed fontanelle, then this is a problem. But in the neonates and the prematures, you can always do that. Especially, you can do that up to 1 year of age, where there is a bandwidth of getting a meningitis. We choose a VP shunt, as I've told, that if the weight of the child is more than 3 kgs, or the child is older than 3 months, and the CSF is sterile. In all other cases, it is recommended, and we have seen by burning our fingers over the years that it is better to do a temporary shunt. Think of an ETV only after 1 year, because as young residents, when you will be doing new cases, ETV has a very steep learning curves. There are anecdotal literatures which have described ETVs in 6 months, 7 months, but these are only for experts. To start with, to do ETV across a 1 year, when the ETV success score is smooth. Otherwise, in small neonates, less than 3 kg, less than 3 months, CSF not sterile, put in a temporary shunt. Don't think twice. It is always how you put the case to the parents. If you say that this is a type of shunt is required, temporary shunt, they will not argue. They will always, and it is best for your child, they will always say yes. Never fear that relatives will say that they will need another operation. We have to come back and do a VP shunt after 3 months, and so don't worry about this. Think of the present and act for the present. Case 2. This is a classic case of a non-communicating hydrocephalus. Communicating hydrocephalus, where you see all ventricles are bigger, and the most important, you see the brain parenchyma. You see the brain parenchyma, there is a lot of what you call a wet brain, lot of CSF sipping out, and this is a telltale sign of a previous infection. And this is usually seen, this is a plain scan, but if you do a contrast, you will see the enhancements of the blood vessels. And even you can see the exudates in the skull base. So it is a post-meningitic hydrocephalus commonly seen in early infancy. Same technique, CSF analysis, temporary shunt. If it is a post-TB meningitis with a poor palliative grade, then do a BP shunt, external ventricular drain, and convert to a BP shunt only after 2 to 3 weeks. Everything works. You can see how the VSG shunt works, is functioning even in a small neonate with an open fontanelle. Case 3. This is a case of as you can see, this is an asymmetrical hydrocephalus. When a small child presents with an asymmetrical hydrocephalus like this, the one side is more dilated than the other, you think of 3 things. Whether he or she was shunted before, so the one side is decompressed more than the other. Number 2, whether there is a spina bifida or associated key, and so that you can have an asymmetrical hydrocephalus in these cases. And then you decide whether the head side is increasing or not. Otherwise, there is a raised ICP features or not. It is better to do a programmable shunt or in some cases, if the child is older than 1 year, to do a foraminoplasty. And if you suspect there is an isolated block in the foramen 1. If you see this picture, there is a increase of there is a dilatation of this temporal lobe. You see, there is a dilatation in the temporoparietal region, signifying there is a raised ICP even with this asymmetrical hydrocephalus. It is better to put in a shunt rather than wait and watch. This case 4, as you can see, that this is a case of there is a Dandy-Walker malformation. Now, in the Dandy-Walker malformation, first trick is not to attack the cerebellar cyst, but to do a BP shunt and wait, and everything will fall on soon. Now, with Dandy-Walker malformation comes another similar thing, that is whether when you're dealing with a hydrocephalus due to posterior fossa tumor. It may be in the brainstem, it may be in the cerebellum. If it is an accessible tumor, it is wise to do a EVD and a tumor excision, or even sometimes a tumor excision without an EVD, but it's always better to do a tumor excision under the cover of an controlled external ventricular vein, and then clamp it and decide whether the shunt is necessary or not. There are a lot of controversies indeed. There are a lot of discussion, as you can see in various conferences. But as young residents, you follow the copybook style. Put in a bar hole, put in an EVD, flip the child, and then operate. If it is an inoperable tumor, then you can consider putting in a permanent shunts. But the shunts usually, say in a central brainstem tumor, are required from both sides. Otherwise, you will end up with a asymmetric hydrocephalus. If you're lucky, you can do away with one shunt. Next, this is a case, as you can see, it's of an older child with a marked hydrocephalus. There's a shunt already put in, which is probably grazing the ventricle. And whether the child has come with a large head, and the parents are asking whether you need to revise this shunt or not. Then you have to look at the brain parenchyma. Look at the brain parenchyma. All sulci and gyri are visible. So there is no raised intracranial tension in this case. Number two, there's no hurry on revising the child. Then you see the thickness of the skull, how the skull bone is thick. So probably this is a case of a chronic hydrocephalus, or what you call an arrested hydrocephalus. It is better not to meddle with this child, except follow it up. I follow this kind of children ophthalmologically, doing fundoscopic examination every 6 months initially, then every year, and just follow them up clinically. Surveillance is a must, and you can see this child. This child is young man now almost 18 years with a large head, and he's still in a follow-up. We are still avoiding a shunt revision in this case. You can see in the bone window how thick is the skull. So in a chronic or an arrested hydrocephalus, just wait and watch and follow the child with occasional MRIs or CTs and after regular ophthalmological examination. This is case 6. This is, as you can see, that this is almost a case of an hydrocephaly with a very thin or absent cortical mantle. As you can see in the lower pictures, there is no cortical mantle. Now, as you know, this hydrocephaly occurs due to an intrauterine vascular event, leading to dysplasia of the cortex, so that everything is filled up with water. By doing a shunt, you cannot alter the CSF dynamics. You cannot make land out of water, and so the brain will not grow. But I say that is very, very difficult to make the parents understand this. They will roam from surgeon to surgeon, asking for a shunt for their child, and many such child do survive. And as you can see in this picture, reasonably, say up to 1 year, 1.5 years, and then you are left up with such a large child, but without any cortical mantle. Whatever the temptation is that, please do not put in a shunt, because a shunt, as I've already told, there are a lot of maladies associated with shunt, and it will add to this another insult to this already damaged brain of this child. So better not to subject this child to anesthesia and surgery, and just make the parents understand, show them the literature, discuss other cases here that you have hydrocephaly you have managed, make them talk to them, and convince them that this is not a case that we can treat by a shunt. This is, you can see, a patient with an hydrocephalus, and this is a CT scan of the skull reconstructed. As you can see, there's a significant copper beaten appearance, suggestive of very raised chronic intracranial hypertension. Now, putting in a shunt in this case, whatever the type of hydrocephalus, can lead to the sudden decompression, can lead to venous hypertension, leading to post-operative bleed inside the cortex, back bleeding inside the cortex, and it may cause a significant life-threatening event. So discuss and discuss before jumping to a shunt. With a patient with a craniosynostosis, with a skull-based synostosis, remember, ETV is not an option. ETV is not an option because the area in the skull base is stenosis and the vertical height is much more. So yeah, and the ETV is not an option. It is better to do a vault expansion surgery and then followed by VP shunt. If you look at the lower pictures here, you can see there is hydrocephalus, but the striking thing is that how shallow is the posterior fossa. See how the posterior fossa is shallow, how the tentorium is almost vertical. The posterior fossa is so shallow. So it is better to have a vault expansion surgery, then if necessary do a VP shunt. But remember that hydrocephalus in craniosynostosis is a difficult thing, and especially with raised intracranial, with a chronic raised intracranial hypertension, and with a skull-based stenosis, we must put in the venous factors into consideration before deciding for the shunts. This is an hydrocephalus caused by a cyst, and as you can see, the cyst is different from what we have. From the cyst consistency is different from the ventricular consistency, and so we have some higher cases of hydrocephalus in parasitic infections. Like this was a case of a hydrocytic cyst. So the treatment is to remove the cyst and then decide whether there is a residual ventriculomegaly or not, and then decide on the shunt. Unless it is a life-threatening event, don't go overboard and put in a shunt first. If there's a very raised intracranial hypertension, you can do an EVD. But the focus should be on doing a craniotomy and removal of the cyst. This is another case where there is an intraventricular neurocysticercosis. Intraventricular neurocysticercosis is quite common. They present dramatically with hydrocephalus. So again, the treatment is to do a endoscopic removal. The scolex easily comes out, like we do in a collosis. It's a similar type of surgery. So we remove the interventricular cyst and avoid doing a shunt. Now, if you can remove the cyst completely, if there are not many of the interventricular scolexes, then you can have a good outcome without a shunt. There may be hydrocephalus associated with encephalocysts. Both the anterior and the posterior encephalocysts may be associated with hydrocephalus. Remember, if you see this picture, you see that there's not much of brain which is protruding outside, but a lot of meninges. And you think I will just remove this defect, excise this glyous tissue, and we'll have everything in place. But remember, come back and see the MRI. See how shallow is the brain, how shallow is the anterior posterior diameter, how shallow is the posterior fossa, how the deformed at the CV junction, how the CV junction is deformed. So this child will go on to develop hydrocephalus. Almost all of these children with encephalocele go on to develop hydrocephalus. At the time of encephalocele surgery, you must tell them and counsel the parents that there will be two surgeries, one for the encephalocele and one for the VP shunt. For the anterior encephaloceles, we put in the shunt first, decompress, repair, and then repair the encephaloceles. For the posterior parietal and posterior encephaloceles, you may excise the encephalocele first and then decompress the brain. Again, the issue of venous hypertension is must be taken into consideration. As you can see, that this kind of ventricle is dragged outside here in this case, and there are, you can see that there are apart from the shallowness of the posterior fossa, the superior sagittal sinus and the sinuses associated with the tentorium are deformed. So again, after a VP shunt, these kind of babies may go on to develop bleeding inside the brain. So that bleeding due to venous hypertension must be explained to the parents. Lastly, in this guy, the last case we'll discuss is whether to do in a to decompress a child with a large head. There are children we encounter in our country who have very large head, cases of neglected hydrocephalus. some without they are doing homeopathy or some other treatment, traditional treatment, not doing the shunt, then bringing the child at the age of 5 months, 7 months, 9 months, and then asking for a shunt, whether to shunt this child or not. Again, there are issues of number one, venous hypertension. Number two, a permanently enlarged head, even after you do a shunt. Number three, the thin shunt may not be able to tackle so much volume of CSF. Fontanelle will never close in this child because of the obvious distension, that chronic distension, and whether to jump in for the shunt or not. See both the pictures. One, you have a child who is sleeping gently in his mother's lap, and other child is very irritable. So you treat the patient and not the radiology. If the baby is in distress, you go on and relieve the ICP by putting in a shunt. If the baby is stable, then you may wait and watch and allow this to develop into a chronic hydrocephalus or an arrested hydrocephalus and hope for the best. But if a baby is in distress, even with a large stent, even if you know that the treatment of hydrocephalus is futile, we need to relieve the suffering of the baby. As doctors, it is our duty to relieve the suffering of the baby and do your best of whatever type of shunt we choose. So what are the take-home thoughts? The take-home thoughts are that, number one, every case is unique. So you look before you live. Discuss with your fellows, discuss with your superiors, and discuss with everyone around the peer group, and take everybody's opinion before putting in shunt. Consider CSF sterility always before a shunt. So therefore, you have to do a CSF analysis in all cases of shunt. Up to 3 months, advisable take home is do a temporary shunt. Remember, whatever type of hydrocephalus, how easy it seems, please do an MRI. You can miss a web inside the ventricle in a CT scan. You put in a shunt, and that ventricle has a web, and your shunt will end in the vein. Please do an MRI. If it is a neonate, you to screen the whole brain and spine, so that an occult spina bifida or an occult chiari is not missed. You choose a VP shunt, whatever is available locally, and with a valve which you are comfortable with, depending on the parameters which I have already described. Younger the child, less is the experimentation. Many shunts are available, many programmable valves with small contour are available. But remember, for a programmable valve with a small contour, which is called a mini Hakim valve, it is very difficult to palpate the valve. Every time you have to, you need to readjust the pressure. You have to take an X-ray and then readjust the pressure, subjecting the child to a lot of X-ray exposures. Plus, the profile, whatever the company describes, as it is small profile, for a neonatal skin, it is nothing called small profile. Every shunt valve can extrude out. The lesser the child, the less the age of the child, more you think of a temporary shunt. Wait for the subcutaneous tissue to develop and then put in a proper valve. Use ETV in very selected indication. Again, for choosing an ETV, talk to the people who have experience in ETV and ask their opinion before choosing an ETV. And ETV only works still only in selected cases. ETV is not the panacea. In a long time, it has been shown nowadays, you must be reading all these papers, that after 1 year or after 2 years or so, in long term, the results of VP shunt and ETV are almost the same. And even in some cases, some reports, the results of VP shunt are better than that of ETV. For a quick decompression in selected cases, ETV is better. But again, choose wisely. Treatment of the cause where indicated, like in tumors, you can avoid putting in a shunt. Even we have a large case studies published in child's nervous system of VSG shunts, where I've shown that around 29% of our patients have avoided permanent shunts if we put in a temporary shunt. Because by that time, when the child is ready for a permanent shunt, the original pathology, like the meningitis, the tubercular meningitis, the germinal matrix hemorrhage is cleared. So even you can avoid a permanent shunt in most of the cases. Not most of the cases, say in 1/3 of the cases. Avoid multiple CT scan. So not at the, I've seen some centers they do CTs, and some centers means some centers which I have worked. Some people tend to do CT scans every now and then, one before the shunt, one after the shunt. No. We try to avoid radiation exposure as to be kept as minimum while putting a shunt. Is a straightforward operation. If you think plan very well, there is no need of doing a post-operative CT scan unless there is an obvious chance of failure. And in multilocular hydrocephalus, which I've deliberately avoided because that discussion is coming up, then we have to do multiple stage procedures. So this is a protocol. What I was discussing of what is the protocol described in this paper? The how to minimize shunt infection. What are the steps as surgeon you can follow in your OT so as to minimize shunt infection? Please go through this paper and follow this protocol and just customize it according to your own OT environment. Thank you so much. At the end, dissatisfied customers is what we are looking for. And so to get a satisfied customers, you need to put a thought about. Never grab a CT scan with a ventriculomegaly and rush to doing a CT scan. Every hydrocephalus, unless there is a bradycardia or something, a big event, can wait for 1 or 2 days and give you some time to think. Thank you for your patient hearing, and I will stop sharing my screen.
Thank you, Kaushik. I think we had an extensive presentation with showing us how detailed the evaluation should be and how important is the decision making at this stage, because one wrong decision can change the life of the family and the child for the lifetime. So beyond this, we have a guest teacher, Dr. Biju Bhadran, who is a professor at Bhadran Medical College, and his residents who are participating in this session. We have started this as a new initiative so that we create rapport between different departments. Dr. Biju, you can introduce your residents and they can present their case. And we'll again look at the decision-making part of the case which they present. And in between, let me remind all the residents who have joined, these are sessions by the IndSPN for you. So please feel free to talk and raise your hands and talk and clarify all your doubts as much as possible within that limited time, of course. Thank you. Dr. Biju, you can present. You can ask your residents to present and you can introduce them, etc. Go ahead, please.
Am I audible?
Yes, you're clear. No issues. Just introduce your residents.
No issue. First of all, thank you, IndSPN and the team for giving us a wonderful opportunity and this distinguished platform for present the cases and discussion. And before going to that discussion, I would like to thank Professor Kaushik for that excellent presentation, very informative, and especially for that representative cases. Which eliminates doubts in the most of the residents and for experienced people also. So thank you so much. We'll move on to the presentations. We have 3 presentations by 3 of our final year residents. First, I would like to Dr. Nitin Das is presenting first. Dr. Nitin Das, Dr. Ravya, and Dr. Vishnu. 3 residents are there. So I would like to ask Nitin Das to share his screen for the presentation.
So in between, any of the residents who have joined, they can raise their hand, stop the presenter, ask questions on whatever they want to understand. And meanwhile, dear residents from Bhadran Medical College, please present. We'll look at the decision-making part. So stress on the initial evaluation and initial diagnosis. Don't go into the discussion because discussion is probably not very important at the moment. Go ahead. Dr. Nitin. Dr. Nitin, you unmute yourself, please.
Am I audible?
Yeah, you are audible. Please proceed.
Sir, good evening, everyone.
Yeah.
So, our cases. of an 8-year-old male patient, female and symmetrical hydrocephalus.
Dr. Nitin, just be loud, please.
And here are
Please make your screen full screen. And a little bit louder, please.
So there's an 8-year-old male child with a lumbar myelomenincocele and asymmetrical hydrocephalus with a paraplegia with no bowel and bladder control. He came to us, our department, in a government medical college, Trivandrum, as a term baby born to an 28-year-old mother G2A1 by normal vaginal delivery. So he was evaluated in his MRI, was showing a lumbar meningocele with an open sac and a shallow posterior cranial fossa with Chiari malformation and a mild to moderate ventriculomegaly with colpocephaly. So he underwent a right VP shunt and a MMC repair under GA on January 2015 from our department. Patient later in December 2015, patient was admitted with a meningitis with a CSF culture showing pseudomonas. That was managed with the IV antibiotics. And after meningitis had settled, he underwent right VP shunt revision with the placement of a DR VP shunt, bacterial resistant VP shunt in December 2015. So MRI taken at the time showing an asymmetrical hydrocephalus and a Chiari malformation with the lumbar myelomenincocele. In July 2016, he was
Hello, doctor.
Hello.
I will interrupt you here. And can you go back to first slide? The previous one. Other one, the history.
Hello, sir.
The history. First page. Uska aage.
It's in the first slide, please. Yeah.
Okay, sir.
Oh, okay, no problem. So was before repairing that of meningomyelocele, was a culture taken from the open sac?
Sir, I didn't get your question.
Before attempting to repair the open meningomyelocele, did you do a swab culture from that meningomyelocele sac?
Yes, sir. Yes, sir. It's an open sac. At the time, we advised for sterile dressings,
And cultures were done.
I have no, sir. I have no details of whether culture was sent from the open sac.
Just for our learning, whatever you have done or not, just for our learning, in an open meningomyelocele comes and you are going to repair immediately, say within 48 hours. If it's an institutional delivery, you are repairing it in the same. Then you send a culture and repair, but don't put in a permanent VP shunt. Do a temporary shunt because it may come out to be an infective one. If the child is being shifted from another institute to your institute, and the placode is possibly infected, if you see the placode and say this is a possibility, it is coming beyond 72 hours, then held back. So just take a culture, start antibiotics, wait for the culture reports, and then do the repair. Nothing will happen in 1 or 2 days, and you will say will be operating on 5th day or 6th day. But remember, if you do a VP shunt, I have not taken a culture from the back before closing the meningocele. What you are doing, you are taking the skin commensals into the thecal sac during the act of operation and the closure, and the baby will go on developing post-operative meningitis. Please carry on.
Can I make a point at this time?
Sir, sir.
Actually, in all ruptured meningomegaly and open meningomegaly, we use take a culture and start appropriate antibiotics before proceeding with the intervention, actually. But I assume that this is actually a long history, and he has started from the beginning, and he didn't get all details.
No, that is right. That is
That's a very valid point that you have given.
that is a take-home point for the residents who are
very important.
listening.
That's very important.
Who are listening.
Thank you. Thank you.
Yeah. Carry on, please. Sir.
July 2016, he was readmitted with abdominal distension and ascites. He was evaluated and was conservatively managed. In February of 2017, the child was readmitted again with the same complaint in lethargy, and he was diagnosed with an abdominal pseudocyst. So in 2017, he underwent excision of the pseudocyst wall and a repositioning of the VP shunt to the peritoneal cavity, right subdiaphragmatic area in March 2017. And in the same year, in 2017 August, and repositioning done to the left subdiaphragmatic area in August 2017. And the next year, February 2018, he again presented with the shunt obstruction, lethargy, abdominal distension, and underwent the laparotomy and a pseudocyst excision with the shunt repositioning in February 2018.
So, Dr. Nitin, we realize we are running into multiple abdominal issues, isn't it?
Yes, sir.
So these were the sequelae of the initial meningitis, the pseudomonas gram-negative meningitis, isn't it? Are you clear?
Yes, sir. The issue of gram-negative meningitis and the initial.
Yeah. So all these are sequelae of gram-negative meningitis that we are getting multiple abdominal issues, multiple pseudocysts again and again, isn't it? Because probably there are additions, and that's why the pseudocysts are developing.
Yes, sir.
At the same time, whenever we have a pseudocyst, we assume there is a chronic infection, and we do not internalize immediately. We externalize. We send the samples for culture, rule out chronic infection by keeping the CSF for 7 to 10 days, because there are sometimes very indolent organisms. Then only we internalize. So it's possible that you had a chronic indolent infection at this time too, when this multiple pseudocysts appeared, and of course. This could have been a sequelae of the old meningitis. Clear?
Yes, sir.
Okay, go ahead, Cynthia. Thank you.
In June 2018, he again had similar symptoms with abdominal distension and a diagnosis of the pseudocyst abdomen. At this time, it was a drain under ultrasound guidance. The shunt was ligated and was converted in the right subgaleal shunt. In 2018 August, we underwent the right subgaleal shunt removal and the right
Pleural.
ventricular. 2019, he was admitted with drowsiness. So right, the ventricular pleural shunt was getting blocked. So underwent left side VP shunt with removal of the ventricular pleural shunt. So just X-ray taken showing the ventricular pleural shunt in situ with the pleural effusion.
Okay. Yeah, Dr. Nitin, one basic factor, what kind of valve do you use for ventricular pleural shunt?
So medium pressure valve.
Yeah, exactly. So one basic fact when we use a ventricular pleural shunt is we don't use medium pressure. We use high pressure, preferably with an anti-siphon device, because the intrathoracic pressure is always negative. So there's a lot of suction effect secondary to the negative intrathoracic pressure. So whenever you want to use a ventricular pleural shunt, you would use a high pressure and probably a programmable with an anti-siphon device. You do not use a regular normal shunt for ventricular pleural shunts. And so this is one of the consequences of ventricular pleural shunt, because the fluid direction is completely one-sided, isn't it? That's why you have this ventricular effusion. Some amount of effusion is tolerated by the older children. So I would be surprised why this child did not tolerate. So I think that's one decision-making point. At the same time, probably at this time, we could have chosen a ventricular atrial shunt, because ventricular atrial shunts are supposed to be more physiological and well tolerated by most older children, at least. Not the youngest one, at least the older children.
Can I make a point?
Yes. Go ahead, Dr. Biju.
Actually, that's
Hmm.
very important thing because this child actually the ventricular shunt actually failed because of the excessive drainage into the pleural cavity. The child developed, I assume, I was not there at the time, dyspnea and respiratory distress, and they had to take out the pleural end.
Yeah, that's what.
And probably
Valve selection is important.
everything is connected to the first meningitis probably, and it has gone to a long-term low-grade infection, which is creating all the issues. And another point about ventricular atrial shunt, when we suspect an infection, I've seen in the past that we had a very few occasions with ventricular atrial, but we have seen that the child developed a bacterial endocarditis following the shunt placement.
Yeah, case selection is very clearly important. I mean, has to be well selected, of course.
Yes.
But ventricular atrial shunts are supposed to be very physiological. Of course, infection and all that issues, basic issues have to be ruled out before we start off with that initiative. Ventricular pleural, I think one aspect I would clearly be different in this case selection was maybe the medium pressure I would have completely avoided and probably used one with an anti-siphon device. Medtronic Strata has an anti-segment device.
That actually, I'll tell you one more thing. This high pressure shunt is not that easy to get. They usually give us medium pressure, and you have to wait for that. And regarding the Medtronic shunts, we have some issues with the cost factor.
Cost, yeah, cost is an issue, but that's why ventricular plurals are usually avoided because all
So,
this negative.
Doctor, whether there was a Chiari malformation in this case?
Yes, sir.
Yes, sir. So with a Chiari malformation and a hydrocephalus, we are shunting. So since the baby is having so many abdominal complications and all with the first shunt, have you at any point of time thought of addressing the Chiari malformation and relief and do away with the shunt permanently? The cause of hydrocephalus is Chiari. Hydrocephalus is not the actual pathology, right?
Yeah, that's correct. Actually, following a myelomeningocele, that shunt was done along with the myelomeningocele.
I am not sitting on the first shunt, during the second failure, the third failure.
Second thing, and first thing, I think we have to relieve the pressure building up.
I agree with you fully, sir, during the first time. But during the second failure or the third failure, when there were repeated abdominal complications, pleural complications, then there was a time where you can just switch on. By that time, the child would have been slightly bigger. So we could have gone back to the.
That should have been a choice or option at the time, actually.
The Chiari, get rid of shunt altogether.
Yeah, and ETV was I mean, probably trial of ETV could have been done.
Yes, but thing is, what is your experience with repairing this Chiari, a surgery for decompression or a Chiari repair? What is your experience with the leak? Do you come across any leaks following the surgery? We don't leave the hydrocephalus before that.
Yeah, we do. So nowadays we go for bony decompression, and then we use an intraoperative ultrasound to check the flow.
That's very good.
And if this intraoperative ultrasound shows that there is a reduced flow, then we make a small durotomy.
Okay.
Then remove the adhesion and do an adequate duroplasty. Where a child, anything across 3 months can tolerate a duroplasty. The dura is be tough enough to suture and do a good duroplasty.
Yeah, correct. Otherwise, you would have done a ventricular subcalation and then do the Chiari.
In my institution,
and then you have waited for some time. And then
in my institution, we always do nowadays all meningomyelocele subgaleal shunts, and then we take a call after 2 months or 3 months.
Okay.
Yes, so the first decision making is very important. I mean, whether the first shunt was required or not is the first. I mean, again, we go back to that question, isn't it? So that's why the decision making becomes very important. Okay, go ahead, Nitin. Dr. Nitin, go ahead, please.
No, 2023 April, he was admitted again with low GCS, decrease of responsiveness for food intake, vomiting, evaluated. Initially, he underwent an EBD insertion in our pediatric ICU, and then once he improved, he was ventilated, and then once he improved, underwent a left PP shunt removal, and revision right PP shunt was done. 2 days later, he developed swelling over the cranial wound site with the abdominal pseudocyst formation, and underwent a laparoscopic guided excision of the pseudocyst, but the swelling over the cranial wound site persisted. Again, this is the post-op CT after the shunt removal, the left shunt insertion. Then he underwent laparotomy, excision of the pseudocyst, with the repositioning of the shunt in the left paracolic space, with the tunneling into the shunt was tunneled through the peritoneum in this sitting. He developed CSF leak from the wound, from the laparotomy wound site, wound gaping, and was conservatively managed. And according to antibiotics were changed according to the culture and sensitivity. And he was improved. Wound became healthy. CSF leak through the wound reduced after 1 week. Child improved. And now he's having full GCS, taking oral feeds. No fever, abdominal distension, and crossing stools. No.
Thank you, Dr. Nitin. Thank you.
Yeah. Suhas, I have a question to Dr. Kaushik.
Yeah.
Kaushik, you were telling in this patient that we should consider the Chiari malformation surgery. So when do you suggest it should be done along with the shunt revision when we are doing when the shunt is malfunctioning, or we should plan it later when the shunt is functioning?
Normally, we do address the Chiari around the age of 8 to 9 months. But if there's an issue of the abdomen, and if there's an issues of multiple shunt failures, then it is always better to address the cause of hydrocephalus and treat it permanently, avoiding a shunt. And in this case, it was possible because the child had an obvious Chiari malformation and some CV junction abnormalities also.
Yeah, Kaushik, I do agree with you, but you see, in all the instances of shunt malformation, there was pseudocyst formation. So, do you think the indicator more will be towards an infective cause?
No, the cause is an infection. I agree with you. In good shape, since no shunt is working. So you consider from the surgeon's point of view, the abdomen is not working, the pleura is not working. There's a risk of bacterial endocarditis from the actual point of view. Then what he'll do? Then the option was probably the only one thing left for us to address the Chiari.
Okay, so you suggest that to address the Chiari, the hydrocephalus might dissolve.
Yeah. Because in most of the meningomyelocele, the hydrocephalus is because of the Chiari.
Okay. Should we go to the next case? Okay. Thank you, Dr. Nitin. Let me remind the residents that just to remind you the lessons which we have learned here. One is the first shunt has been important. Whether we do not know whether the first shunt was necessary or not, or could have been postponed. Second is we have seen that there are multiple other options of shunt that is possible. That's ventricular peritoneal versus ventricular pleural, ventricular atrial, ETV, Chiari decompression. These are other possibilities. So the first decision making became very important in this particular child. And the third last thing which I would remark is when you have a child with myelomeningocele and Chiari, the threshold for a revision of shunt should be very low, because since the tonsils are very low lying, the patient can decompensate and have a respiratory arrest very quickly by the time you try to understand the whole scenario. So moving ahead with the fast shunt is very important in these kids. Next, you can have the next case. Dr. Ravya?
Thank you, sir.
Who is the next case?
Yes, sir.
Dr. Biju?
Yes, sir.
Ravya, please share your screen.
Yes, sir.
Actually, I would like to make a point, because
Yes.
The last time, like I've taken that case particularly because of the complications I've seen. It's not a frequent case, but once in a while we see that. Another
Yeah,
thing
yeah.
is very difficult to make parents understand about the multiple procedures that may have to do. Then many of time we lose a follow-up. They'll go
Yeah.
to some other center or a pediatric neurology follow-up. Then they come back up when there is a failure or a complication. That's another problem.
That always
Yeah.
happens. Part and parcel of our life.
Go ahead, please.
Ravi, please share your screen. I think you have to give a permission to share screen.
Yes, sir.
Okay.
Am I audible, sir?
Yeah, you're very audible.
Thank you. Good evening. Today we will be discussing about Elizabeth King meningitis and post-meningitic hydrocephalus. The
Share
index.
screen.
The screen is not visible.
Dear Ravi, if you have any difficulty, we'll move on with the other presentation.
Yeah, I think Biju, Dr. Biju, we can have the third case then,
Ravi?
because we're running out of time. That's
Okay, sir. I need some time.
So we'll move with the Vishnu's presentation. Okay.
Yes, sir.
Yes, sir.
Vishnu, are you there?
Yes, sir. Yes, sir.
Can you share the screen and start the presentation? Vishnu, make it full screen.
Sir, am I audible?
Yeah, come on.
Good evening, everyone. So I am discussing a case of a challenging case of hydrocephalus. So my patient is a 2-year-old female child coming from Trivandrum. She presented to us with reduced responsiveness and poor intake for 2 days. And child is born at 32 weeks of gestation. Second child of a non-consanguineous marriage, born out of LSCS, birth weight was 2.6 kg, birth circumference is 36 centimeter birth. During immediate postnatal period, baby was in neonatal ICU in view of pneumonia and was on ventilatory support. After 10 days, the child is better improving and out of ventilator and was discharged. Again, at 4 months of age, child was admitted with fever and decreased response. And CT head shows hydrocephalus. CSF was aspirated and CSF culture suggestive of meningitis and treated with IV antibiotics. Multiple aspiration of CSF done through AF and EVD was also inserted at that time. Then he underwent right VP shunt, Sabras medium pressure non-programmable shunt insertion. After that, the child improved in post-operative period and was discharged.
Dr. Vishnu,
Yes, sir.
can I ask you something here?
Yes, sir.
Go back to the previous slide. Now, so when you have a child who has meningitis, at what stage will you consider putting a shunt? After how much of duration of antibiotics, etc.? So you have a child who's actively who has active hydrocephalus, isn't it?
Yes, yes, sir.
So just tell me what do you think should be the timing of the shunt? How do you decide when to put the shunt for the child with meningitis who has active hydrocephalus and who's sick?
After 2 sterile culture, CSF culture.
Yeah, but you have a child who is drowsy, who is keeping on vomiting, and who may even crash, isn't it?
Yes, sir.
So
What procedure will you do when you see such a child who is deteriorating rapidly?
First, we will consider an EVD, sir.
yeah, so like
is
if
an
you
aspiration
look
or
at the if you listen to Kaushik's talk,
Yes.
a ventricular subgaleal shunt is an adequately equivalently important option. That's an option you could have used.
Yes,
Or
sir.
in EVD, but the EVD is one problem with EVD in these children it's difficult to control the amount of output, and it can be unsafe when you leave it in the ward or the ICU with the nurse who may not be used to handling EVDs.
That's a very practical point, actually.
Yes, sir.
Yeah. So,
And
one is, as you said, you need two sterile samples, and at the same time, in between, you need to have an interim measure for CSF diversion.
Yes, sir.
Okay.
And what about the
So,
protein level?
I think I have a question
Protein level and the
to ask.
cell count.
Yes.
Like,
Yeah,
do you prefer putting a medium pressure shunt for these child with post-meningitic hydrocephalus at 4 months of age?
Yeah. So actually, this was happening in local hospital, not from by us. This is
Okay,
considered a private hospital.
Okay.
We did the history also. The child present was at only at 2 years.
Okay.
Okay. Dr. Biju was asking about the protein level. At least the literature does not support this high protein level having high malfunction.
Yes,
You might use a shunt. You might have a repeated blockade, but at least that should not stop you from doing a shunt.
yes.
Yeah. But when the protein content is more than 2 grams per liter, then the chance of blockage
High
is very
chance of
high.
malfunction. Yes.
Chance of malfunction is high, especially with
Yes.
high cell count also.
Agreed.
Do you have any preference of this between the different brands, in especially when the protein is high or cell count is high?
No, so
this,
we try to avoid the programmable shunts, especially with high protein protein content, because if we lose the shunt, especially a costly shunt, we would lose the shunt, isn't it?
Cost factor, because the cost factor. Okay.
Yeah, so exactly. So we preferably use the regular ones only.
Okay, thank you.
Go ahead, Vishnu.
And at 8 months of age, the child presented with increasing head circumference and poor feeding of 2 days duration. On examination, the child was drowsy and anti-inflammatory tense. The child was having development delay with sunsetting signs of the eyes. When the right VP shunt chamber is not functioning, the CT is suggestive of multiloculated hydrocephalus. That time, also an emergency EVD was done to decrease intracranial pressure. Then CSF values, protein, sugar, cytology, and culture everything were normal at that time. Then this is a in the CT image, the multiloculated hydrocephalus with right VP shunt in situ with non-functioning. Then multiple.
Vishnu, what is the organism?
Sir?
What was the organism?
I didn't find any details of it. It is not mentioned actually. Culture organism was not mentioned.
Yeah, usually it's gram-negative organism.
Gram-negative,
What are the usual organisms that you come across there?
Gram-negative.
Yeah, it depends on the age, depends on the history, etc. Yeah.
At that time, the child underwent right revision and removal of the previous shunt. Same also, the child improved in posterior and hence discharge. This was happened in local hospital. And child present was at the age of 2 years. Then with a decreased response and poor feeding, the child is drowsy and this time head circumference was around 52 centimeters. We have done a CT and MRI with suggestive of multiloculated hydrocephalus. This is MRI filling, right? Dilated ventricles and septations in between. The right side of the front horn is also dilated and with septations. This is the CT scan of the same change. Then we have the child has undergone multiple aspirations with 2 times EVD and 2 VP shunts. Then we have what plan we have just we search the literature. For the time sake, I'm skipping the literature reviews. Then so we planned. Our goal was to make maximum communications between the maximum possible number of isolated parts of the ventricular system. So that's our goal. Then we created openings in the septal walls, and the CSF drainage will be achieved by minimal number of shunts. So this
Dr. Vishnu, hello. Now how do you rule out infection in such a multiloculated hydrocephalus? Where did you tap from, or where do you tap from?
Actually, the ideal thing is if it is neuronavigation gadget is good, but we
No,
tap
no.
from
No,
No,
my
the
question,
question is,
no.
the question is, does the catheter tip has any bearing on the infection thing
No,
or any contrast?
yes,
if you
there
say
may be
contrast,
infection in one compartment and
sir.
and the
Yeah,
other compartment may be
one of the
sterile.
compartments can be infected. So you need a contrast MRI.
Sir.
You understand, no? So
sir.
otherwise, you will land. You might have an abscess which is sitting there. The kind of MRI which you showed shows very abnormal kind of periventricular lucency, which is not just possibly not just hydrocephalus only. It might be infection along with it.
Yes, sir.
So contrast MRI is very important to rule out even loculated abscess, etc.
In all suspected cases of infections inside there, before putting in a shunt, do a contrast MRI to rule out ventriculitis.
Yeah.
Yes, sir.
Otherwise, you will put in a shunt tube inside that
Yeah,
ventriculitis
yes,
chamber.
sir,
Not in this case, even in all cases.
yeah,
Any
okay.
post-infective hydrocephalus, the take home is to do a contrast MRI before putting in a shunt.
And at the same time, you should have a systemic infective profile study. So if you have a child with such a scan and an abnormal CRP, even the abnormal CRP might reflect the fact that the child has an abscess or meningitis.
Very high CRP is also a negative factor for poor
Yes.
prognostic factor.
Yes. Go ahead, Dr. Vishnu.
So we used endoscopic surgery along with the help of neuronavigations, which improve the localization of the cyst. So the child underwent endoscopic fenestration of multiple cysts under neuronavigation guidance, and septum pellucidum was fenestrated. After endoscopic fenestration, this right PP shunt endoscopic guide was inserted, and child improved after the procedure and was discharged. So actually, this was imaging. We selected the maximum maximum connections, intended pathway, and advanced the proximal catheter into the ventricular system. This catheter is introduced, and under these are the neuronavigation slides. This neuronavigation, we make use of the neuronavigation to get the maximum path, connecting the maximum number of cyst walls. Then the shunt is introduced.
Actually, these
Yes,
are
sir.
repetitive.
Next.
Actually,
Yes.
this multilocally hydrocephalus, multilocally or presence of infection in any of the locally is a difficult
Yes.
scenario.
Yeah.
Then what we have to do is planning is very important. Pre-op planning is very important. Which way, or you have to use sometimes multiple access points to get this locally connected. And some of the smaller locally we have to leave, and the major locally are connected. And either, if possible, with navigation, you can identify. Sometimes after especially after infection, meningitis or intraventricular hemorrhages, the anatomy is so deranged that you have difficulty to identify the front Monroe or third ventricle or anything.
Yeah.
In such cases, you have to go in with the VP shunt, or otherwise, if it's possible to identify this anatomy, then you can proceed with this. My question is, in many cases of this infection and all those things, this choroid plexus cauterization, what about that option?
The other thing which is, before answering your question, the other thing which is which comes in very handy here is a contrast ventriculogram. So
Yes,
once you put in a EVD, you say put in a contrast, take a CT scan and see which way it is flowing. A contrast ventriculogram comes in very handy in understanding which locally you can do it.
Communications
in our settings. Navigation gives a 2D thing that it never gives that 3D feeling that where to go and exactly, so that you don't lose path later on. About the choroid plexus,
Does it initiate any reactions, any ventricular reactions? This dye, because we had a patient with the thing. I think the dye which you inject through a lumbar puncture and through directly to the ventricle is different. The concentration is different, I think. Am I correct?
Yeah.
Dilution is considered, but the dye is same.
Dye is the same. It is hyperdiluted.
Yeah, just hyperdiluted. That's all. Depending on the amount of space you want to.
The ventricular stage. The radiologist will calculate that for you.
Yeah.
And about Dr. Shwas, who would like that question on choroid plexus?
The choroid plexus. Yeah, most of the infected ones, the choroid plexus is already very damaged. Especially after meningitis.
Scarring may be there, But there are papers saying that ETV combined with the choroid plexus CPC is better.
Yeah, that is for infants with meningitis, not with older children with multilocate hydrocephalus.
Yeah, that's what I meant is infection.
Yeah.
That's what I said earlier.
Yeah, infants with post-infective hydrocephalus, CPC improves the success of endoscopy.
Yeah, post-infective.
Yeah, not for a multilocate. Multilocate is different completely.
Multilocate is different.
Everything is burnt out.
Talking about post-meningitic hydrocephalus.
Yes. And another thing is, ideally, for the sake of residents, you can have introp MRIs and introp imaging too, to complete the theoretical part of discussion here. Okay, Dr. Vishnu, have you finished?
Yes, sir.
Okay, thank you. I think that was a nice case, and multilocate hydrocephalus is always a difficult challenge to manage.
There is a comment from Dr. Suchanda Bhattacharya that endoscopy with ultrasound guided also works best.
Yes.
For
you look for air bubbles passing across the different loculi. Thank you, Dr. Suchanda. Kaushik,
actually, thank you.
Yeah, Kaushik, I think we should stop, isn't it?
Yeah.
8:30.
8:15.
Shall we stop here?
We have one more presentation. If you permit, we can just have
So can we have it quickly? Not an issue. Yeah, since the resident is prepared for it, yes. Is she ready for it?
Ravia, can you hear me?
Can you hear me?
Yes.
Okay. Come on. Make it full screen.
Yeah.
Elizabeth Kingham meningitis and host meningitic hydrocephalus. The index case is a term baby whose birth weight was 1.39 kg, and a postnatal day 18, the child developed continuous fever. She was evaluated and found to have Elizabeth Kingham meningitis. The child had increasing head circumference since 1.5 months, and serial AF tapping was done. When the child presented to us at 4 months of age, the child was active, alert, feeding adequately with a bulging AF. Head circumference was 31 centimeters at 2 months of age. When she presented to us, it was 40 centimeters with a positive sunset sign. The CSF analysis was serially done by the Department of Neonatology there then, and it isolated Elizabeth Kingham with a sugar of 30 and protein of 220 with a total count of 10 cells. They initiated her with meropenem, amikacin, ciprofloxacin, followed by cefoperazone sulbactam, when the isolate was again Elizabeth Kingham, which responded only to cefoperazone and sulbactam. The serial CSF studies data shows sterile cultures with an increasing sugar.
These are lumbar CSF.
Lumbar CSF, yes, sir. Since the child presented with progressive increase in head circumference with a positive sunset sign and an AF bulge persisted at 4 months of age, MRI imaging and CSF analysis. Following MRI imaging and CSF analysis, a decision for VP shunt was made. This was her image, which shows periventricular lucencies. Post-operatively, the child improved symptomatically, became less irritable, AF was flush, sunset sign disappeared, and the head circumference was static at 40 centimeters after 2 months of follow-up. Coming on to Elizabeth Kingham meningitis. It's a non-fermentive gram-negative bacilli, ubiquitously found in hospital environments, inherently resistant to multiple antimicrobials. Upon discussion with the neonatology department, they advocate 6 weeks and IV antibiotics, which respond according to the sensitivity. It causes outbreaks in the neonatal ICUs. It's a hospital emergent infection and are related to contaminated medical equipments. Can cause severe infection with high risk of mortality and neurological sequelae in neonates. We have a study, IndSPN study. It's an interim report of the study to study the clinical profile of neonates with Elizabeth Kingham meningitis in neonatal ICU and the need of shunt procedures in the study group. Here, the birth weight, the age of presentation, the clinical features, the CRP, platelet count, meningitis, duration of antibiotics, outcome, developmental anomalies, and the treatment was started. Around 13 cases in an 18-month study period of Elizabeth Kingham meningitis was isolated. And among them, 3 children required BP shunt. On 2 monthly follow-up, the 2 children, except the one, were doing well with the oral antibiotics continuation. To conclude, early suspicion sensitive antibiotics may prevent the development of severe complications of meningitis. Frank bus appearance of CSF should raise the suspicion of Elizabeth Kinge meningoseptica. Septran or ciprofloxacin or vancomycin or cefoperazone sulbactam can be added to be replaced with conventional empiric treatment of neonatal meningitis till culture results are available. Those cases where ciprofloxacin was added early in the course did not develop ventriculitis and showed rapid clearance of CSF, did not require multiple antibiotics later. VP shunt procedure done in 3 out of the 13 cases on a 3-month follow-up were symptomatically better with no shunt-related complications. It required multiple and prolonged antibiotics in meningitis, unlike other bacterial meningitis. Also, active infection control in hospital environment is necessary to prevent Elizabeth Kinge meningoseptica epidemics.
What were the gap between putting detection of hydrocephalus and putting the shunts?
2 to 3 weeks after we waited for the culture result to become sterile and the sugar and the protein to become lesser than the initial one. The protein to become lesser, the sugar to increase.
The sugar will never become normal in 2-3 weeks, as you can understand. And 2 of your patients, of the 7 patients shown in the slide, expired by day 11. So
that's why we included this.
I know.
Even if the name looks very attractive, but this is actually a very deadly infection. And one particular point is many times what we see is in many peripheral centers sometimes they give us suboptimal antibiotics, so they may not have a proper diagnosis. So this complication, all meningitis won't go for a VP shunt recommend, or go for a hydrocephalus. 10-20% may go for a CSF, acute CSF diversion recommend. Among that, a few may go for a shunt insertion. So I think improper treatment, delayed diagnosis leads to the these kind of complications.
Agree, sir. But from the basis of today's discussion, sir, any kind of infection, please do a this for the residents, of course. Please do a temporary shunt. Never think of a BP shunt.
In all these cases, that's our protocol. In all these cases, we do either.
I know you do. This is for the residents who have joined outside your department.
We do an aspiration first. That's sent for analysis. If needed, we'll put a EVD. That's a very good pediatric IC we have, and then if requires, we'll go for a subgaleal shunt or young children, less than 3 months.
Do one subgaleal shunt, then if it is blocked, change to the other side. Wait till the infection burns out, and then put in a BP shunt.
That's right.
So in every case, what we have discussed today, there's very nice cases. Please, in all infection for the residents, do not jump into putting BP shunt at any point, because whenever you get a shunt infection, the pediatrician, everything, they will wash their hands off and say, this is a surgical complication, and parents will run after you.
That's correct. That's correct.
Thank you.
Thank you very much.
Kaushik, we'll stop here. Okay, so thank you, Dr. Vishnu, Dr. Ravya, and Dr. Nitin. Thank you. You presented very well, and you made a very good attempt. Thank you, Dr. Biju Bhadran, for joining us. And I think your department, your department did a great contribution in today's session. And of course, my own colleagues, Dr. Kaushik and Dr. Naveen and Dr. Shibu, who are participating, and Dr. Suchinda. Thanks, everybody. At the same time, let me remind all the residents that all these virtual classrooms are meant for you. And we have planned about 24 to 30 classes over each, one per month, every last Sunday of each month. In between the same time, 7 to 8 p.m. and the last Sunday. And the next session is on 25th of June, where we are talking about post-hemorrhagic hydrocephalus. So more of post-hemorrhagic hydrocephalus and its management on the next session. That's on 25th of June, 7 to 8 o'clock. Thank you very much. And we will be circulating a Google form wherein you can put your email ID, etc., where we will keep you updated about the classes, etc. And moreover, all these classes will be recorded, are recorded, and will be available in a separate channel, which we are going to start, and at the website as a continuous repository of all the topics. So we will be covering all the topics for you in pediatric neurosurgery from here onwards. Is that okay? Thank-
Can I make a point?
Yeah,
Can I
go
make a
ahead.
point? I should congratulate the IndSPN for initiating this such a great initiative. It's a great initiative. Actually, many centers or many places, this pediatric cases, especially hydrocephalus case, so myelomenicosis, are referred to in the centers most of the time, or sometimes neglected. Neglect by the parents, neglect by the, of course, by our caregivers. But I think they should start a new lesson or new era. Okay, thank you.
Thanks a lot. Thank you, Dr. Biju. Remind your residents to keep joining us every month with the classes, and of course, it will be available too. Thanks a lot. Thank you.
Thank you.
Thank you all. Good night.
Thank you.
Good night.
Thank
Good
you.
night. Thank you.
Good night.
Good night.